Thank you so much, Bernie. It's really good to for you all to join us today for our TMC seminar. I'm Warren Kinghorn. I co-direct the Theology, Medicine, and Culture Initiative, and it's really my immense pleasure to introduce our speaker for today, Dr. Harold Koenig, my colleague here at Duke University Medical Center and Duke University. I've known Dr. Koenig for many years now, and he's been a generous friend and supporter of TMC. Dr. Koenig is a psychiatrist who directs the Center for Spirituality, Theology, and Health, which is a sibling initiative here at Duke that's centered in the School of Medicine. We're centered in the Divinity School, but Dr. Koenig Center is in the School of Medicine. And for many years, Dr. Koenig has been a national and, in fact, world leader in especially the empirical relationship between religion, spirituality, and health. And that's what we're going to be talking about today. Dr. Koenig is professor of psychiatry and behavioral sciences at Duke, an associate professor of medicine. He also has adjunct faculty appointments at universities in Saudi Arabia, Iran, and China, which may be the only Duke faculty member that can say that. Dr. Koenig completed his undergraduate education at Stanford, his MD at UC San Francisco, and first trained as in family medicine and geriatric medicine before training in psychiatry and geriatric psychiatry. Dr. Koenig has a long list of honors and awards, but suffice it to say that for many decades, he's been awarded on a wide variety of levels, from the American Psychiatric Association to the American Association of Christian Counselors to many others, for his work really thinking about how do we think scientifically about the connection between religion, religious practice, religious belief, spirituality, and health. And it's just an incredible honor for you to be here with us today. I would also say Dr. Koenig has published prolifically and is the lead author of the Magisterial Handbook of Religion and Health, which is now in its third edition, that is really the central volume for thinking about overall, how do we catalog the relationship between religion and health. So Harold, thank you so much for being with us today. It's really an honor for you to be with us and to share your perspectives with us. And I have a few questions for you, and then we'll be in conversation together, and then we'll invite the group into conversation with us.
Thank you, Warren.
Yeah. So thanks for being with us today. Would you just start by sharing your own story of medical formation and training? And what were your steps along the way? And how did you first become interested in the connections between religion and health?
So when I was in medical school, I had some problems there, and I dropped out in my second year, and then went through a period of soul searching until I became a nurse, a registered nurse, and then went back to medical school, completed that, and then went into family medicine in Columbia, Missouri. And so I began doing research at that time, back in, the 1980s, mid-1980s, and began to look at this connection between faith and health. I got particularly interested when I was a family physician because many patients would say that religion was helping them to cope with their illness. I had been, as a nurse, you're trained to ask people, how are you coping? How are you getting along here? So I continued it as a family doctor. And I heard people say, they prayed and their church was praying for them. Their minister came by and encouraged them. And all of that was very helpful. And these seemed to be patients who were doing pretty well. And so I thought, why not systematically look at this? Because as you know, Warren, in medical school, we're taught by the latest research. And so I thought maybe documenting just the frequency that people turn to their religious faith. This was just south of Chicago. Just documenting that would be helpful. And so in any case, I then, tried to convince my other family doctors that this was an important area worth studying or worth paying attention to. There was no interest whatsoever. And so I felt a bit like an outsider there. And so then I continued to do the research, and then came to Duke in 1986. and began studying geriatric internal medicine. So did that for 3 years, got a degree in biostatistics, and then thought, well, this area is close to medicine, but it seems to be closer to psychiatry. So I thought maybe I ought to go through psychiatry training. So I went through a psychiatry residency and a geriatric psychiatry fellowship, and then joined the faculty here and continued to do research along these lines, and got some funding support from the Templeton Foundation and other grants from the NIH. And I just throughout that time I was looking at this connection between health, faith and health, mental health, and then physical health and behavioral health, social health. So that's kind of what I've been doing over the last 40 years.
Yeah, I love that. Well, among other things, I hear you saying that if you want to practice medicine as it's supposed to be practiced, you train as a psychiatrist, right? So
There you
we
go.
can agree on that, right? So,
Exactly.
yeah,
We totally agree.
exactly. That's right. Well, I'm conscious in our work here at the Divinity School that when we think about the connection between faith and health, that we're building on the shoulders of you and of others who have come before us to pave the way. And I'm aware that you also are conscious of building on the work of others. And so you mentioned that when you started being interested in these questions in the mid 1980s, there wasn't much interest in the clinical world around measuring and really thinking carefully about the relationship between faith and health. And yet there began to be a movement. I wonder if you could tell us a bit about that. You might call it the religion and health movement that began in the mid to late part of the 20th century and continues to this day. For those who aren't familiar with it, like how did it come to be? And as one who was part of that movement, like how have you experienced it?
So, in the around 1950, David Moberg, who was a sociologist from, I think, Wisconsin, somewhere up there, he began looking at the role that church membership played in health.
Yeah.
I mean, mental health in particular. So I remember, seeing his work, and then, of course, David Larson came up to Duke back in I think the early 80s to work with Bill Wilson, who was a professor of psychiatry here at Duke. And so he then began to look at this connection between mental health and religious faith, and from a scientific standpoint, from a research standpoint. And so he developed a center there in Washington, D.C. He worked for a while at the NIH, and then he developed his own institute.
David Larson,
David Larson
developed a center, right?
Yeah, he developed his center in Washington that encouraged bringing people together interested in this topic, like Jeff Levin and many other people who had many of these people had trained under Bill Wilson here at Duke, and then they had left to go to other places. But that's kind of how it got going. And then Dave Larson and myself and Mike McCullough wrote the first edition of the handbook, which was in 2001. And that helped to bring a lot of the research all together that had been scattered around and that nobody really knew how much work had been done or what had been found. So we kind of brought it all together, and that was in 2001. And I've had many colleagues in the field over the years, helping John Petit from Harvard and Tyler Vanderweel, of course, from Harvard, and many others who a lot of them were people of faith themselves, got interested in this and realized that this was something relevant to their work and that they could integrate this into their patient care, because many of their patients were very religious and they were using it to help them to cope with their illness.
Yeah. And then began to look at it carefully and to produce a body that's now pretty mature at this point. Yeah.
Yes, sir.
So you're not though just a disinterested social scientific researcher. You yourself are a practicing Christian, and I wonder, since this is a series where we talk about theology and faith and health, Uh, what does, how do your Christian commitments matter for your work in the clinic, but also for your research work?
Yeah, so it really matters, I think, in the clinic,
Mhm.
because when I was seeing patients, um, I would often pray for them on my own, and that really changed my whole attitude during the time that I saw them.
Mhm.
I feel like I was more compassionate, I was more interested in them personally. It just really made a huge difference.
Mhm.
And um, then in terms of the research, I think it's helped me to be more rigorous in the work that I do, because I want to be honest. I don't want to cheat. I don't want to allow my own biases. I mean, certainly religious faith has transformed my own life.
Mhm.
And so I don't want that to enter into the work. So science provides a framework that enables you to set aside your biases and to look at things objectively. And so that's what I've tried to do. And I think my Christian faith has helped me to be more rigorous in that and not try to cut corners,
Uh,
um, so to speak, in order to, show what I believe. But rather than to look at what do people believe, how does that relate to their health, and what can we do to help to bolster that faith so it'll work even better for
mm.
them coping with their illnesses?
Yeah. It sounds like it comes out of an intuition that you experienced caring for your patients as a nurse and then as a physician in the 1980s, that there's something that's constructive about religious faith for many people, maybe not for all people, but for many people. Has that been something that you've been kind of then wanting to kind of submit to scientific scrutiny over the years?
Yes, certainly many people have trouble believing,
Mhm.
or they have negative experiences within religious communities.
Mhm.
But for the vast majority of people who are out there in the public, religion is a real resource for
Yeah.
them, a real resource to help them to cope with loss and change. Life is hard. Life is hard, especially as you grow older.
Yeah.
Life gets
Yeah.
increasingly hard.
Yeah.
And you need something a little bit more than, your own resources. And so
Yeah.
many people relate to that, and they find that believing in God, praying to God, being part of a faith community, reading the scriptures and getting direction there, it really does make their lives happier and fuller, and
Yeah.
it helps their relationships.
Yeah. So let's unpack some of that because I'd love for you to tell us a little bit about the kind of trends in the literature over the past decade or two. First of all, there's a constant debate in the literature about how to distinguish between the concept of religion and the concept of spirituality. And I wonder if you could talk about your understanding of that distinction, if at all.
So, this is a hot topic, the distinction between religion and spirituality. And there's not much agreement on it.
Mhm.
After many, many different conferences and discussions,
Mhm.
people feel very strongly one way or the other.
Mhm.
So, um, you know, people who are called spiritual, according to the traditional model, were a group of deeply religious people.
Mhm.
They were typically the clergy
Mhm.
or religious leaders like Jesus or Gandhi, the Buddha. Uh, these were the Prophet Muhammad. These were the spiritual people whose lives really were focused on their religious faith, which
Mhm.
informed their actions and their purpose in life. So those were the spiritual. But as things over the last 20 or 30 years have gone into the scientific world,
Mhm.
which is largely secular, the word spirituality has expanded
Mhm.
to beyond just religion to include those who are not religious, those who are completely secular. Um, and so the big question is, how do you measure spirituality? How do you measure that
Mhm.
from a scientific standpoint? How do you quantify it, especially in quantitative research?
Mhm.
And what's happened is that spirituality has expanded beyond just the religion and the outside of religion to include indicators of mental health.
Hmm.
So now spirituality has defined as good mental health from the beginning,
Mhm.
and the measures are assessing mental health, not anything distinctively spiritual or religious. Right? The word spiritual comes, as you know, from Genesis with the spirit hovering above the water. This is clearly a religious term.
Hmm.
And things get very confusing when you start measuring spirituality as mental health, as positive mental health, meaning and purpose in life.
Mhm.
Um, Connectedness with others, existential well-being, peacefulness. All of this has been part of what spirituality has been defined as, and measures
Mhm.
of spirituality have then included these items. So whenever you look at the connection between spirituality defined like this and mental or physical health outcomes, naturally you find positive correlations.
Right,
You're just correlating something with itself.
right.
So, while spirituality is a wonderful word to use in clinical practice,
Mhm.
where you want to invite everybody to the table, and
Mhm.
spirituality is largely self-defined.
Mhm.
But when you're looking at research that's trying to identify causal factors that you can intervene on to improve health,
Mhm.
spirituality just doesn't work. It's just too
Mhm.
broad and diffuse, too self-defined.
Mhm.
So therefore, religion is largely what is being measured that is distinctive enough and different enough from mental health to potentially influence mental health in various ways. So,
Yeah,
um,
that's really interesting. I want to ask you more about religion specifically, but I'm hearing in what you said that one is that we can respect that there are some people who consider themselves spiritual but not religious, that there's empirical utility in thinking about spirituality different from religion because some people resonate with that, but be aware of any absolute distinction between spirituality and religion,
yeah,
and also beware of ways of defining spirituality that include like high levels of flourishing or mental health. So then if you
exactly.
say, okay, high spirituality is high flourishing, and therefore spirituality causes high flourishing, you're engaging in tautology or
Exactly.
nonsense, like you're just defining things as they are. So
Exactly.
that's a really good caution for all of us, I think, in the
Yeah.
clinical world. So say some more about religion specifically, and specifically religious practice, and maybe even more specifically religious service attendance. What have you learned over the years about the correlations between religious service attendance and religious community participation and religious practice and various markers of health, both physical health and also mental health?
Yeah, Warren, there's no question that the strongest predictor of good mental, social, physical, and behavioral health, all aspects of health, is engagement within a religious community. Research repeatedly has shown in large studies, thousands, tens of thousands of people followed over decades of time, that those who are engaged in a religious community do better in every aspect of their life. They live longer, they have lower blood pressure, virtually everything is better health-wise for those engaging in or television or music, all of those things, in combination with being engaged in a faith community, this combination seems to have some of the greatest effects, even greater than just religious attendance on its own.
Yeah. So that gets to what a skeptic might say, well, great, religious community is great, but it's just social connection. We're lonely in our world and we need each other. So, how as a researcher would you disentangle or control for the effect of simply being connected to other people from specifically religious practices and religious service attendance?
Yeah, that's a very good question and a common one that I often am asked. Um, we have statistical methods that control for, take into account social engagement.
Yeah.
And in virtually all of the studies that I'm referring to, social support, while it's part of the mechanism by which religious involvement does enhance a person's health, even when you control for it, the effects remain there. It only really explains about 25% of the effect. So the remaining 75% has to do with beliefs and attitudes and practices.
That's really interesting. So it helps to account for part of the variance, but not all of it. That's really interesting.
Nowhere near all of it.
Could you talk specifically about mental health outcomes, depression, anxiety? How do you see religious practices affecting mental health outcomes specifically?
Yeah, so I think probably uh, the biggest effect that religion has is going to be on health behaviors that
Hmm.
influence a person's mental and social health.
Hmm.
So it's those religious rules
Hmm.
that the people who are spiritual would like to do away with
Hmm.
and live life on their own that seem to help to enhance our well-being and our flourishing. It's almost as though God has made these rules for our benefit,
Hmm.
not just to spoil our fun, but it's for our benefit. And so when people live healthier lives, um, they experience better mental health. Now, that's certainly we understand there are genetic factors that influence risk, vulnerability to depression, anxiety, substance use disorders. But
Hmm.
given all of those things being equal,
Hmm.
religious involvement just helps people again to live in a way that enables them to experience greater satisfaction, greater meaning and purpose in life, better relationships with others as they follow, the great commandment to love your neighbor, be kind to others.
Hmm.
All of this comes back to you, and you
Hmm.
realize that this all is a part of flourishing. Um, and so, it's mental health across the board. Now, of course, it's a little hard to actually identify this,
Hmm.
particularly with cross-sectional studies,
Hmm.
because you've got two moving targets here. One is your mental health,
Right,
which may be improving or getting worse.
right.
And then you have your religious involvement, which is responding to because of the coping,
So you feel
because
better and you go to church or synagogue.
right.
Yeah, yeah. Hmm.
Yeah, and so, it's like, and when you get distressed, you pray. When you don't have any other avenue available,
Hmm.
you get on your knees. And so that creates this positive association between religious involvement and anxiety, for example,
Hmm.
or chronic pain,
Hmm.
because people turn to religion for comfort to cope with the distress that they're experiencing. Now, if you follow people over time, over long periods of time, over 10, 20 years,
Hmm.
you can see this, you can see that separate out. You can see that then religion is helping to prevent the development of anxiety, helps to increase the pain threshold that people experience, all of these things. But again, it requires follow-up over time or even a randomized controlled trial, although those are difficult to do.
Yeah. Let me ask you about the flip side of that, because we all know that, and your work shows that most of the time, religious practice is positively associated with better health. But there's maybe about 1 in 5 studies that show actually an inverse relationship, that religion can be associated with poorer health of various sorts. And as we all know, religious communities can harm and can be sites of deep pain. And I wonder if you could talk about that. Like how might religion actually be a kind of negative force for health and flourishing?
Yeah, so religious involvement, as you said, is not always associated with flourishing and better mental health. Um, People turn to religion often. Wounded people turn to religion for comfort, but their wounds are not entirely healed a
Mhm.
lot of times. So there's still, people who can hurt others
Mhm.
within the religious community. So while it's very helpful in general, some people remain wounded and then in turn wound others within the faith community. There are also individuals who might genetically be predisposed to guilt, or shame, or have adverse childhood experiences that make them more vulnerable to these emotions. And then they go into religion and they misinterpret, I think. They begin to see God as, as causing them to feel guilty for their normal natural drives, and their guilt is expanded, it gets greater, their shame becomes greater because they can't live up to the high standards that religious faith holds in terms of moral and ethical values. And then they become distressed over that, a form of moral injury, we might
Mhm.
we might
Mhm.
say. So religion can harm, because religion includes people, and people harm others. And so that's naturally that shouldn't be the case, but that's just the way it is.
Yeah.
And so,
Well, I'd say there's not, it's not just that individuals may be vulnerable, but there can be structural patterns within religious communities that perpetuate harm
mm,
around trauma and violence and
oh
other
gosh,
things. And so it's a, I appreciate the way that you kind of hold those things in nuance, that for most people, religious practice is really powerful as a contributor to health, but there's also sometimes where it can be the inverse.
it can. I mean, if you take some of the radical viewpoints that take religion beyond where it really ought to be, um, it can be destructive, as we've seen all over the world.
Yeah.
Devout religious faith has caused terrorist attacks, it's caused everything. People are in wars over religion, are they not?
Yeah.
You know,
Yeah.
it's been the humanity's history of wars rooted in a lot of times religious beliefs.
Yeah. Yeah, let me pivot a little bit back to the clinic and to the like your engagement with patients and what you've learned about how clinicians engage with their patients. A number of years ago, you did a study here at Duke around hospitalized older adults and asked them about how important their faith was to them, and the results were a little surprising. So can you talk about that study and what you've learned over the years about the degree to which people facing serious illness, especially later in life, um, think about their faith as an important aspect of their coping with illness.
Yeah, Warren, this is kind of where I started out when I came
Yeah,
here many years ago. I was asking people, how are you coping? I did that in a systematic way, as I said earlier.
yeah,
Um, and what I learned, I did it at the VA, and then later, then I did it at Duke Hospital.
yeah,
So among older adults at Duke Hospital, now this is in the 90s,
yeah.
9 out of 10 people indicated that they used religion at least to some degree to
Mhm.
make sense of their medical illness,
Mhm.
their their disability, their chronic pain, their just their the losses that getting older and getting sick caused in their lives. That religion was at least to some degree used to enable them to deal with all of these changes, especially hospitalized older adults who are really having health issues. They oftentimes, I mean, where else, could they turn? I mean, the doctors and nurses, sure, it's great modern medicine, but there are limits to modern medicine, and ultimately you're left kind of on your own.
Mhm.
And then what do you have? Well, many people may not have family members surrounding them and supporting them.
Mhm.
Um, but there's always God, and there's always a faith community that you can be part of that can help support you, pray for you, encourage you, take you to the doctor. All these things that the faith community can do, and your own personal connection with God that that even if you die, there is something beyond just death. We're just our physical bodies, we're all going to die someday.
Yeah.
And so what happens then? What
Yeah.
happens then?
Yeah. How can people of faith um, not be avoiding death, but actually in some ways like looking death square in the face, recognizing that death doesn't have the last word.
Exactly.
Yeah. Yeah.
That's what we believe.
So Duke is Duke in every system is probably a more pluralistic now and maybe a little more secular than it was in the 1990s. But there's still a lot of people for whom faith is really important to them, not only here but elsewhere. How would you recommend, let's say that there's a nurse or a physician or a occupational therapist who is engaging someone in an inpatient medical setting. They don't know the patient well, but they want to ask, like they don't want to just avoid it. How would you recommend going about asking someone about how faith is important to them?
So I would encourage all healthcare professionals to take a spiritual history.
Mhm.
That's what I would call it. It would be a spiritual history. It could be done as part of the social history during the initial evaluation, admission to a hospital or a nursing home, or even potentially even in the clinic, seeing the patient for the first time during a well person visit. So taking a spiritual history, ensuring that it's patient-centered.
Mhm.
So, asking the person, do you have any spiritual or religious beliefs that provide you comfort or are a cause of stress for you?
Mhm.
And then going on, do you have any spiritual beliefs that might influence your medical decisions or decisions about your psychiatric care? Are there any spiritual needs related to the illness that you're coming in here for help for? Is there any spiritual issues that might be connected there? And then allowing that person to talk about those issues. Just a few, maybe a minute or two.
Yeah.
It's hard to kind of keep it into a minute or two, but often patients understand that
Yeah.
physicians are busy
It doesn't take that much time to
it
ask
does.
the question. Yeah.
It really
Yeah.
does. A lot of times I'll just say, how are you doing spiritually?
Yeah.
And that's it.
Yeah. Yeah. I've asked that question before too, and
Really?
people are sometimes like really surprised to be asked that,
Oh,
but then such rich things emerge. So
oh my
I love that.
gosh.
Yeah. Yeah. Let me ask you a couple more questions, and then we'll open it up to the group if that's okay.
Okay.
I mean, some of the critics of the empirical religion and health movement, both secular critics but also religious critics, have charged that worry that it can become a way of like making religion into just one more therapy or just one more technology that doctors or clinicians will recommend and it takes it out of the context of a religious tradition and more into the context of modern medicine. So the worry is that like if prayer is helpful for preventing anxiety, then as a psychiatrist, I could just prescribe prayer and patients could do that to try to avoid feeling anxious, but that's not really the purpose of prayer. How would you respond to those critics and those who are concerned about that?
I think that's a very serious concern. Um, and people who are using religion for some other means, whether that to bring comfort or to be socially, more acceptable, etc., that's an extrinsic form of religious involvement, and that is not related to your health. It's intrinsic religious involvement where your goal is religion. That's what you're after. It's your primary thing you're going for.
Mm.
And so you can't just take religion and use it as an instrument, just as a tool to feel better or to be healthier, because it just won't work. You see, you can't go for health and flourishing directly. You have to go through the religious pathways that are described in terms of the beliefs and devotion and living your life surrendered to God. And when you do that, all of the flourishing just comes along with it. It just naturally occurs because God loves us, wants us to flourish. And if we submit to Him, we're submitting to His way for us to flourish.
Jesus has some words to say about seeking first the kingdom, but also about where your treasure is, there will your heart be also.
Mm,
And I wonder if our treasure is in our physical health or even in our mental health,
mm.
that actually that becomes a kind of distraction in some ways from the fullness of life.
I agree totally.
Yeah,
Totally. I think that's true.
yeah. I've been asking you a lot of things about what you did for the first few decades of your career, but for a lot of the last 10 years, you've been focused in not a completely different, but a slightly different direction, thinking specifically about the phenomenon of moral injury. And you've really become a key contributor to the empirical work on moral injury, especially as it relates to religion. I know this is I'm just asking this question at the tail end of our interview, but I wonder if you could say how you understand what is moral injury and why is it an important concept, and what have you learned over the last few years as you've been researching it?
So Warren, within 12 hours, I'm going to be giving a full day talk on
So
Saturday,
you have a lot of
tomorrow.
thoughts right now about this.
Yeah,
Yeah, yeah,
8 hours worth of training on moral injury. That's
yes,
tomorrow.
good.
So if anybody wants to attend, send me an email. I'm
Yeah,
happy to.
yeah.
But in any case, so moral injury involves, there are three different aspects. One is the commission of moral transgressions. That is where it's basically sin.
Hmm.
You're transgressing moral ethical values. You're hurting someone. You're doing something that's wrong.
Hmm.
So that's one aspect of moral injury. The other aspect is observing others commit transgressions,
Hmm.
um, doing wrong things, and being able to do something about it, but not doing anything. So that's another form of moral injury.
Hmm.
Then there is a form of moral injury where you're observing people doing bad things, but you can't do anything about it, and you just feel bad that just the world is like this.
Hmm.
Where people are harming and hurting each other. And then there's being the victim of somebody else's moral transgressions, being you know, either being, abused or being commanded, for example, in the military to do something wrong by your commanding officer, feeling betrayed by them because they're asking you to do something that's immoral. Or even in the healthcare setting, a nurse given an order by a doctor to do something that they feel is not morally right. And yet they're having to carry it out because either the hospital system or the physician requires that for them to keep their job. So there are a wide variety of forms of moral injury, um, especially experienced by those in the military during combat situations, um, in healthcare during pandemics where people are having to just be left to die because we don't have the resources,
Hmm.
by police, firemen, emergency medical technicians,
Hmm.
emergency responders who are seeing horrible things that they can't do anything about. And all of these create these moral emotions of shame, guilt, self-condemnation, difficulty forgiving, religious struggles,
Hmm.
loss of faith, even as a result of these experiences. So
Yeah.
it's a big area.
So I can't just end in despair. So what are some of the things that you've learned can be helpful for those that have experienced moral injury? What kind of responses are helpful and healing and constructive, especially as relates to religion, but not just that?
So, it's helping people deal with the symptoms of moral injury really belongs in the hands of the clergy. The
Hmm.
clergy who are trained in either clinical pastoral education or have some kind of mental health training. But really, it's the chaplains and the clergy which for throughout human history have been dealing with these issues of moral transgressions.
Hmm.
I mean, this is all of the major world religions deal with sin that people commit, the wrong, the transgressions that go against the moral values, which are largely universal, no matter what religious faith that you're holding to it, based on the five major religious traditions that have persisted over time.
Hmm.
Even in cultures that are far away from from modern cultures like in New Guinea or the depths of Australia or other little islands in the Pacific or African areas. They have virtually the same moral values without any connection with our culture. It seems to be these and if you transgress them, you will experience these emotions just because you're human. Now, there are some people who are genetically, just biologically have deficits in their brain and nervous system. They're called psychopaths that don't experience these negative moral emotions when they transgress moral values, when they hurt other people. It makes them feel good. They actually get an adrenaline rush from torturing and hurting people and being totally self-centered, no empathy whatsoever. And their brains are actually different when you look at them, and even their genetic makeup seems to they have a higher pain threshold. They don't experience pain as much. And so I don't understand that, but there are things that you can do, and certainly within the Christian tradition, that's why Jesus came, because we're all guilty, right? We're all guilty of sin.
We understand confession and reconciliation.
Absolutely. Those are the big ones. The big ones are confession, reconciliation with God, and then doing something good in the world to make up for whatever it is.
Yeah. So I hear you say that this should be in the hands of clergy, which is a powerful and strong statement. For those who are clinicians, or who are not just clinicians, but who are observers to systems in which moral injury is created, like the military or healthcare, what role can clinicians play in recognizing and helping with the healing of moral injury, or should it only be something that's the domain of chaplains and clergy?
I think that clinicians can certainly screen for it in anyone who is having been through a severely traumatic experience or been to war or involved in a helping profession or any at risk for experiencing moral injury. We have a 10-item screening measure that you can administer. And after, depending on the amount of disability that it's causing, the person may reach the clinical threshold for referral to a clergy person who can address these issues, like a chaplain. It's usually a chaplain who's trained and who's a lot of times, having a board certified chaplain is even better, but they don't have to be board certified. Just somebody who has a good clinical sense, as a kind person who will create a safe spot where the person can confess and they can then,
I'm hearing a strong affirmation for the role of chaplains as really
absolutely
critical leaders and colleagues and partners in thinking about moral injury.
Absolutely.
I'd love to open it up to the group, but we have Q&A questions that I'm about to look at that have come in from the group. While I'm looking at the Q&A questions, one last question for you. I said earlier that the Center for Spirituality, Theology, and Health is distinct from Theology, Medicine, and Culture as a sibling initiative here at Center here at Duke. If folks who are listening today or who watch the recording of this seminar want to connect more to the Center for Spirituality, Theology, and Health, how might they do so? And what resources do you offer? And what would you invite people into who might be interested in connecting?
So they can, if they're interested in connecting, particularly with regard to engaging in one of our workshops, which we're holding all throughout the year, different workshops on moral injury, on human flourishing, on flourishing in marriage, integrating spirituality into patient care, and actually learning how to do research in this area. Just have them send me an email, harold.koenig@duke.edu, or go to our website where we've got lots of information. And that's just put in Center for Spirituality, Theology, and Health into the Google search, and it'll come right up.
Great.
Lots of resources, free, and also things that cost a bit.
Great. And we had one question in the chat about accessing the moral injury training tomorrow. Is that something that people could find information about on the website?
They can absolutely go to our website, find that information, or just send me an email. I'm happy to send them the information they need to participate tomorrow.
Great, great. Thank you. Yeah. We have a few questions that have come in. I'll go in order, if that's okay. Jonathan Good asks, is there research into differences between people engaged in religious communities versus those engaged in distinctly secular communities?
Usually when you're doing research and you're examining the effects of engagement in a religious community on a health outcome, you are also measuring engagement in secular communities. Number of social contacts, number of people you contact on the phone daily, number of groups that you participate in the community. All of these things are typically measured and then removed, taken away. And then what is left is the finding. So even in Europe, involvement, and there's been some comparison between secular and religious groups in Europe, which is, very secular, but it appears that being part of a religious group specifically is related to health benefits, above and beyond that related to secular groups. And part of it has to do with the love thy neighbor issue. That the fact that you're commanded to love your neighbor. I mean, whether you want to or not, whether it feels good or not, you're commanded to do it. Even your enemy, you're commanded to love. So that's part of it.
I also wonder whether something about the kind of practices that religious communities engage in around sharing meals, around worshiping together, singing together, providing care, that certainly there are completely secular groups that do those kinds of things, but I wonder if there's something about the balance of all that seems distinctive about.
I think it is just like praying together, singing together, worshiping God together, eating together and having, fellowship. All of this combined, in addition to the religious belief that commands we do this. See, that's the belief is what makes the difference, I think.
And we need this as human beings.
We need this. This is part of our nature.
One comment I just want to reflect. Philip Cooper says, as a palliative care physician and Anglican priest working in a Canadian province, which is increasingly promoting euthanasia or medical assistance in dying, he says, I've experienced moral injury on an almost daily basis for the past 10 years since the law changed to permit this. So just reflecting, I think, the importance of your
there's no question that this can create moral injury, and you need to figure out a way to deal with those emotions. There's just it's kind of the form of being a victim. This is kind of being a victim of the situation that you can't do anything about, and so how do you deal with those emotions that it arises? Again, what can you do but to just surrender it all to Jesus?
That's the top that could be topic for another TMC seminar to think about neglected dying and euthanasia and assisted suicide.
Oh my gosh.
Christina Griffin asks, when someone is dealing with existential spiritual crisis and a spiritual history has been documented, but the patient is not a spiritual person, would you recommend consulting a chaplain? To avoid offending the patient, would you explain to the patient that the chaplain can provide moral support? I think the gist is, like, if somebody's not spiritual, or at least hasn't identified themselves, what role can chaplains play, and how would you recommend engaging chaplains?
So chaplains are trained, of course, to deal with people of all different religions and of no religion. So chaplains, what they do is they will walk alongside that person. They will create a safe space where that person can talk about their struggles, whatever it is they're dealing with, and they'll listen and they'll reflect back to them, trying to understand how they're feeling and what they're going through, and without praying or mentioning God at all. They provide a wonderful safe space for people who are spiritual or not spiritual. I think isn't that your experience too?
Yes, I hear you say, it is my experience, and I hear you say, err on the side of getting the chaplain involved.
Absolutely.
And trust that relationship will go well.
Yes. And explain to as this person said, explain to the patient what the chaplain will do, because patients don't know. They just think they're a clergy person that they're gonna, they're gonna try to evangelize, and they don't understand what a chaplain does. So it's
Right,
important to explain that.
right, right, right. Um, Liza McDonald says, what are research areas of religion and health that you are excited about going forward, whether that's research being conducted or research being accepted?
I think we are still at the edge of all of this, just the verge. I think so many areas need to be studied with regard to health and religious involvement, need to be documented in a rigorous scientific manner. The challenge is getting the funding support to do this research in a rigorous way, because sure, you can send out a questionnaire, and that may be very helpful, and you may learn a lot from that. But the real studies that are needed are the longitudinal studies that follow people over time and provide an element of time such that we can say that it's the religion that led to the health benefit.
Mhm.
This causality is something that needs further establishment. And ultimately, it will probably end up with with a randomized clinical trial, although again, they're very expensive, hard to do, and hard. But if you have a religious or spiritual intervention, you can do a single group experimental study where you would assess them beforehand
Mhm.
and then afterward, and then just document the difference that's occurred. And that itself can be very useful and helpful.
Mhm. So in other words, need more research funding to do the careful work that you're
Oh my
describing.
gosh, we need a lot more funding support
Yeah,
from
yeah,
NIH and from other private foundations
yeah,
to do good research.
yeah. I would welcome the group to contribute more questions. I do have a couple of more questions for you, if that's okay.
Sure.
One just has to do with interreligious collaboration. So one of the things that I've had the privilege of speaking for the last several years in your summer spirituality and health research seminar, which is always an amazing event. But one of the things that's amazing about it is people come from all over the world to learn from you and to learn about this work, and they
We
come from,
so appreciate your being involved in
well,
this.
vice versa.
We wouldn't have anyone with your level of theological
Yeah,
knowledge that
vice versa. And I think one of the things that I appreciate is that also the number of different religious traditions that people represent. You yourself have done significant consulting in Iran and Saudi Arabia. That's amazing that actually, given the differences between those two countries, that you're doing that, and also in China and elsewhere. What have you learned? You yourself are a Christian and a practicing Christian, but you find ways to connect with folks, especially in Islam, but also in other religious traditions and Judaism. What have you learned about collaborating with folks across religious traditions around these questions?
I think I've been particularly influenced by the personal relationships that I've developed with people from other faith traditions. And it just seems to me um, that they love God just like I do. And it's hard to say, okay, they're wrong, or they're gonna go to hell or whatever. It's hard to say that when you see somebody who is living a faithful life, believes in God, is serving God, is surrendering their life to God. How it's hard to make sense of that. In many respects, I think the way I understand it is that they're actually serving Jesus Christ, but they don't know it. They don't know it, but they're serving Jesus Christ as well. And
So as a
and
Christian, that's the kind of interpretation that you'd make.
yeah, that's as a Christian,
They
I
may not
would.
say that, but as a
They
Christian,
may
yeah.
no, they wouldn't say that. But I would. What I've done with Islam, I've said, and in Islam it says that God has 99 different names, and I'll just say Jesus is just another one of those, of the 100th name that we call God is Jesus. And I know it's a lot more complex than that,
Yeah.
Warren, as you know, as a theologian,
Our
but
Muslim colleagues might say, "Well, I'm not sure
yeah,
about that." Yeah,
I know that,
yeah,
but you're trying to develop some common ground where you can show respect for, and you can really support, and I try to do that. I try to look for this common ground, and I see a lot of it, and it says somewhere in the scriptures that God takes care of those outside of the Christian faith. We don't have to worry. I think Paul said that. We don't have to worry too much. I mean, naturally, we try to evangelize people, but God will take care of them. And I think that maybe, now I'm not 100% sure with this, but I think that God is speaking to them in the language of their culture and their tradition. That many of these individuals will never believe in Jesus, will never surrender their lives to Jesus, the Jewish man. Certainly, vast majority of Islam, and there will be more Muslims in this world than Christians in the next 50 years. And so God must have a plan for these people. He must. And I'm trying to understand. Don't totally understand it yet, Warren,
Yeah.
but he must
Yeah.
have a plan.
I think these are deep theological waters that we
Oh
obviously
my
are not
gosh.
getting into. But one of the things that I appreciate about you, Dr. Koenig, is you've been at this for a long time, and yet you have a disposition that remains open to wonder and surprise. And I just appreciate that about you. So thank you.
Thank you.
Thank you so much for being with us today. Thanks for being a partner here at Duke and the work that we collaborate on. And thanks for your work and for your presence here at the TMC seminar.
Thank you, Warren. Thank you so much.
So I want to say to all of you, thank you for joining us, and please join us again for our TMC seminar series this fall. Thank you all. Have a wonderful day and go in peace. Thank you.